Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
Well, welcome everyone. I'm Brigid Maloney.
And I'm obstetrician Dr. Patrick Maloney.
And we thought we'd do another quick Q&A because they were like piling up, Pat.
Yeah, well, this is great because we love responding to what people are curious about.
Yeah.
And also they come in from all over the world, which is really cool.
Yeah, it is. Well, look, I know you're a man of action and you just want to get straight into it, don't you? Good. Let's listen to this one.
Hi, Bridget and Dr. Pat. My name's Laura, and I'm the proud mum of a 4.5-month-old who was born 8 weeks premature and despite a difficult start is now absolutely thriving. I just want to say a huge thank you to you both for your podcast. At my 12-week scan, I found out I was high risk for preeclampsia, and listening to your episode on preeclampsia helped me to spot the early signs when I began developing the condition at week 29 of my pregnancy. I ended up becoming quite unwell and was admitted to hospital, and after almost 2 weeks of worsening symptoms, I had an emergency C-section at 31 weeks. My baby was severely growth restricted and had to stay in NICU for almost 8 weeks. I experienced respiratory failure during my C-section and damage to my heart. The whole experience was extremely traumatic and has left me wondering if I could bring myself to get pregnant again. My first question is, what options do I have for learning more about what happened to me and what went wrong and how to come to terms and process the trauma? And how likely am I to get preeclampsia a second time around? Secondly, I really struggled to breastfeed my baby and suffered from low supply. I was wondering if this is a possible effect of preeclampsia or the medications that I'm on to control blood pressure. Thank you very much once again.
Gosh.
Wow.
There's a lot there.
Yeah, there is a lot there. Let's concentrate on a few parts of that. We could probably talk about that scenario all day.
Yeah.
Yeah. So well done for doing it as well as you have done in an enormously difficult and a reassuringly rare situation. This is rare stuff.
And she's right to say it was traumatic. And there's trauma.
It is traumatic.
Yeah. And anyone with one of those issues
yes.
would have said that their pregnancy and birth was traumatic.
Yeah.
Yeah, but, I mean, you've got 3 or 4.
Yeah. So off the top of my head, one of the questions that really stands out there, and it will certainly be of interest to the other listeners, is where do I go to find out what happened to me? Okay. Now, when somebody has been in a hospital and has been really sick, this sounds like somebody who's been really sick, then we want to we walk away from that, and it's not enough to walk out of the hospital and just be alive and to be grateful for that. We are owed by the system an explanation of what happened to me, and that is available to you. You should. I don't know where you're from and exactly what hospital, private, public, whatever, but an explanation, a satisfactory explanation in the form of a clinical debrief really should be available to you. So people who go into hospitals as a private patient, it's obvious that their private doctor is the person who can meet with them afterwards and provide that. And for people who go into the hospital in Australia as a public patient, then contacting the head of unit of that public unit is the appropriate person to make contact with. And there'll be an established protocol to sit down with people who've had a typical course in their treatment. Either they got way sicker, or a clinical error was made, or they had a rare complication of a procedure or treatment. There is a process in place that at an appropriate time in the future we can sit down together and talk about that person's progress through the hospital and a traumatic event.
And maybe to prepare for that meeting, what I find useful for me if there's a situation where I need some answers, my answers, my issues that I have may be very easily sort of explained. So I make a big brain dump, write everything down. Would something like that be helpful if someone's going to a birth debrief, for example?
Absolutely, yes. So preparation is important for doing the debrief properly. People find it quite unsatisfactory if they come to do a debrief in a hospital setting and the person that they're doing the debrief with isn't across the actual detail of what happened to that person, and that people there can be further loss of confidence. So both the patient and the caregivers need to come to the debrief well prepared. Yeah.
And can you request, like sometimes people who do the debrief, like you just said, are the debriefers. They're not necessarily people who have been involved in your direct care. Can someone say in a public system, say, look, I request that someone that was involved in my care on that day is at the debrief?
I guess you could ask.
Yeah.
And that may or may not be possible, but you can certainly ask. I find that if people come afterwards with a lot of questions, then a shopping list of questions is really important so that things don't get forgotten. And then if I'm providing the information from the medical side of things on the debrief, it's amazing that if there's a 20 point, and there might be a 20 point, this case would have a 20 point questions, you might find that 12 can be immediately and easily answered and very satisfactorily so. Yeah. And then there'll be some that require much more discussion, and there'll be some that can't be satisfactorily answered at that initial meeting. And they might need to get another opinion, for example. So our caller went on to ask about chances of it happening again. That's a really complicated question, and there is no easy answer. And we've done another episode on maternal fetal medicine specialists, and I reckon the last 2 or 3 times I have referred people to maternal fetal medicine specialists for a non-pregnant consultation, it's to answer questions like this.
Oh, well, that's really good. A good sort of piece of advice, really, is that she goes along to someone that can give her probably more reassurance about choosing to have another child.
Or just the data, just the up-to-date data from an expert. You may not be able to get a really great answer to that from your obstetrician or from the head of unit at your local public hospital. This might be worth a non-pregnant consultation with a maternal fetal medicine expert where they say, look, the chances of all that happening to you back then were this, and your number came up and you got very sick. The chances of recurrence are blah, blah, blah. And current data, current expertise, current understanding is you can do the following things to help prevent that outcome. Yeah. And people can go into another pregnancy with their eyes open. Yeah.
And role of maybe having a psychologist talk to her through the trauma of this all?
Yes. So she mentioned trauma and she mentioned psychological fallout from what was a really complex and serious situation. So there are some people, I'll say, as a practicing obstetrician, there are some people who I make mental health referrals for because they are telling me they want one. There are some people I make mental health referrals for because I can see signs of mental health distress in that person. And then there are some people where you just think, I'm not. You might think you're handling this absolutely brilliantly, but oh my God, it was such a big deal that I think you should go anyway, even if you don't particularly need to feel that you need to.
Yeah. I mean, she's so switched on, even talking about it in this question. She might fall into that camp.
Yeah, she sounds sort of all over it, but that's a big deal.
Yeah.
And unpacking some of that with a mental health professional would be really good. Even if you don't feel severe dysfunction related to it right now, that might be something you want to avoid.
Yeah, and also, like, you want to avoid that, having to deal with that whilst you might be 30 weeks pregnant
again,
with the next baby.
And a trigger you might feel in a situation of a new pregnancy.
Yeah. Thank you so much for calling in. Good luck with your decision making and your treatment that you have from now on.
Yeah, good luck.
My name's Ashley and I'm currently not pregnant. Hi, Dr. Pat and Brigid. Thank you so much for your podcast and helping so many people navigate sometimes tricky and confusing times. My question is about hymens, particularly septates. I'm 36 and unfortunately lost my first pregnancy at 6 weeks. After a D&C, I was told what I had and it could be removed. Is it best to have it removed before I fall again? And if I didn't, would this be troublesome for a vaginal birth? Little bit of context, it's over 1 centimetre wide, but never painful. Thank you.
Before you get into this, Patty, can you just talk about the anatomy first? I'm a bit confused.
Yeah, so hymenal septums are a part of a group of slight anatomical abnormalities to the genital tract, and you can have a septum, which is a wall, means wall, in the uterus itself. You can have one that runs up and down the vagina, and sometimes all it is a relatively minor situation where it's just a little midline structure, a band of tissue that runs usually up and down ways right at the vaginal opening, as if it's part of the hymen itself. And typically a band like that, sometimes a woman can have had it forever, obviously, and have even been sexually active and so forth. I just never noticed it was there, because the band can be easily pushed to one side. And if the tissue is stretchy enough, then it can allow for perfectly normal intercourse, and it just gets pushed to one side.
Not painful?
Well, no, I've had plenty of people tell me that they just never knew about it.
Yeah, right.
Yeah, and whether it was always pushed to the same side or maybe sometimes one side or the other. Other people are aware of it. Some young people notice it even before first intercourse if they're trying to use a tampon, and they just notice that there's a band of tissue there. They're easy to treat. Typically, it's under a brief general anaesthetic, and you just tie off the top and the bottom and diathermy off the band of tissue in the middle, and it just creates one opening, which is normal. If that's there, 1 centimetre wide is very wide, and if it's not causing problems with intercourse, which doesn't sound like this person's band is, then the septum is, then it doesn't technically need treatment. If people want it treated, then have it treated before you get pregnant would be most convenient. Yeah, and then, but if it's still there when a pregnancy comes around, I can't imagine that it would be a problem in particular. And it may be that the vaginal birth breaks the band anyway.
Anyway, yeah, right. Interesting. We are fascinating, us women.
Lots of little of relatively minor abnormalities of genital tract anatomy happen. And some are related to significant problems like recurrent miscarriage, and others are a matter of personal choice.
And ones in the vagina wouldn't have anything to do with, say, recurrent miscarriage?
No, well, the vaginal ones, no, but they might cause difficulty with intercourse, for example.
Yeah, I see.
And come to light that way.
Yeah, good. Well, good luck with that, Ashley, making that decision.
Hi, Dr. Pat and Brigid. My name is Ellie. I'm 30 years old and currently trying to conceive my first child. First and foremost, I want to say thank you guys so much for this incredible podcast. It has been the best one that I've been listening to ever since starting this journey. And I also have to say that you both have the most soothing voices, and it really instills a sense of calm within me. For some background, I was diagnosed with mild PCOS and currently taking letrozole for ovulation induction, and we have been trying for about 8 months. My question is about cervical mucus, in particular, egg white cervical mucus. I read a lot of things online saying that it's very important to experience some form of egg white cervical mucus around the time of ovulation because this is supposed to help the sperm move towards the egg and also a way to track your cycles. But unfortunately, no matter how hard I look, I've never personally experienced this, and what I usually see is something that's very wet and white in color. So I just wanted to know what you think about if this would be one of the reasons why we're not conceiving, and does this mean that I would need to move on to something like IUI? Thank you so much, guys.
Yeah, excellent question. Brings up a few different things. Ovulation induction is a treatment we use when the what's behind a couple's subfertility is that the woman is not ovulating, or not ovulating at a reliable time, or not ovulating every month of the every cycle of the year. So it's a pretty straightforward thing to do. We use a drug called letrozole, which at the very start of the month helps the ovary pick a follicle and mature it up. And as I say to people, you got to find an egg and say you are the chosen one for this month. Mature it up and pop it out. What we're looking for then is that replicates a textbook cycle and helps the woman ovulate on about day 14. Now, in a totally normal cycle, some women will experience an egg white mucus in the middle of the cycle, and it's nice if it's there, but it's too inconsistently present, and it's too open to interpretation what exactly an egg white mucus sort of feels like. So if you're not getting that, that's not as important as whether the letrozole is working. So I encourage my patients on letrozole to look out for signs of ovulation. And remember, if someone's had bad PCOS for a long time and have basically never ovulated or almost never ovulated, then they won't be familiar with mid-cycle symptoms because those are related to ovulation and they don't have that. So you start that woman up on letrozole and suddenly she gets a cycle of a normal length, she might conceive, but she will, if it's working and she's ovulating on day 14, she'll start getting some mid-cycle symptoms. So sometimes a little bit of pain in the pelvis, particularly on one side, mid-cycle changes in mood, libido, and sometimes changes in cervical mucus, but perhaps not reliable enough. So by the time we've got all the way to using letrozole, I don't encourage my patients to worry too much if textbook signs of mid-cycle activity are not there. But if we've got any doubt that whether it's working or not, we need a day 21 progesterone test. That's a highly objective sign test that'll tell us if the progesterone level's high, then ovulation has actually occurred. Yeah.
It doesn't, like, if this caller has been on letrozole for 8 months, she also doesn't say whether she's having the day 21 test, and she also doesn't say whether she's having some ultrasound monitoring.
Yeah, so I'm not worried. To answer her specific question, I'm not worried that she's not developing egg white mucus. Too open to interpretation. What I would want to know in someone who hasn't had success yet in 8 months of letrozole is, number one, is a day 12 ultrasound showing a convincing follicle development.
Yeah.
Okay, remember, the follicle on a day 12 scan should be visible. You can't see the egg in it, but you can see on the ultrasound the follicle the egg's going to burst out of. And ideally there's one, that we've got the letrozole dose right, so that there's one, not zero, not two, and that we're all set up for ovulation in a couple of days' time. Then a week after ovulation, I want to be testing progesterone to make sure that it's worked. Yeah. And lastly, 8 months is a fair time on letrozole.
Yeah.
Yep. So I would not be talking to my care providers about the absence or presence of egg white mucus. I'd be talking about how much longer we're going to go on letrozole before we change the plan.
Yeah.
Yeah.
And yeah, she also didn't say whether she's having a GP monitor or manage that, or a gynecologist. Yeah. But it sounds like there's a couple of things that are missing, and that's
potentially. Yeah. We don't know, but we just in broad terms, in reproductive interventions, in broad terms, we don't keep doing the same thing forever, hoping for a different result. We try things for a period of time, and if that's not successful, we move on to something else.
Yeah, good. All right, so it's time for you to go back and talk to your care providers and just say, look.
Yep, but I'm not specifically worried about the absence of egg white mucus.
No. Good. I hope that helps, and good luck. I hope you see 2 lines on the P on the stick very soon.
Good luck.
Hi, Dr. Pat and Brigid. My name's Nicole and I'm pregnant with my 4th. My first 3 births were all quite quick. So my first was about 4 hours, my second was 2 hours, and my third was about recorded time of 45 minutes. Is it likely that I will have another quick birth this time round? Thank you.
4 babies, woohoo!
Yeah, well done. Good on you. That's terrific. Yeah, they're getting fast, aren't they? Yep, it is likely. It's not a precise science. So sometimes there are things that might happen in a 4th birth, slide back down again. Yeah, like you might have had 3 babies that were in perfect OA position with the chins tucked down towards the chest and the small diameter of the fetal head pointing towards the birth canal, and they came out really fast and really well. Then you might have an OP baby that has to turn 180 degrees, pivot the head 180 degrees in labour, and that can take a while. But most likely, yeah, it'll be fast and potentially even faster than the babies you've had already. So what do we do about that? It all depends on really the circumstances, and if we look at the people I'm looking after, they're people who've planned a hospital birth, hopefully a very low intervention hospital birth for their 4th baby, but a hospital birth nonetheless, and they are sort of often asking my advice about that. And some of my patients working in a regional area in Australia are from a long way away. So we talk about options for those people, and I'm very much happy to let my patients guide me here. But things we sometimes do is saying, rightio, do you feel confident to come down in labour? Depends how far away they live and what sort of time frames we're talking about.
Oh, sometimes it's like they live 3 hours away. Like,
yeah,
that's
they
a bit
live
long,
3 hours
yeah.
away, and this next labour probably won't be 3 hours long. Then then I say to some of those people, is it practical for you to come down to us, not for hospital admission, but just to come down to our town for at about 38 and a half or 39 weeks and wait for spontaneous labour? And that one usually gets my vote. It's got the benefits of safety without unnecessary intervention. And then lastly, there's some people who say, well, I'm happy to come down, but I can't sit around for 2 weeks, away from my farm waiting for baby to come. Is it safe for me to be induced? And that's a slightly more complex question, and it really matters what the cervix is doing in late pregnancy. So I would be relatively uncomfortable doing an induction for distance from the hospital in someone who was perhaps having their first baby and had a long and closed cervix. If interfering there, we'd be asking for problems. If someone is at 39 and a half weeks in their 4th pregnancy, and when you do the vaginal examination, the cervix is 3 centimetres open, they're not in labour, it's just sitting there. And the head is really well down, and it would be quite straightforward to break the waters and help that woman come into labour. Then that would be a relatively low risk intervention, and something that they might prefer to the risks of having a baby outside the hospital if they come down in spontaneous labour.
Yeah.
So that's a conversation I have every month.
And I mean, this conversation could happen even if she lived 20 minutes from the hospital, but it was in a city and you just couldn't bet on the traffic. Even 20 minutes. When I did my training at a city hospital, we had a few babies in the parking garage and in the street. Yeah. So we actually did an episode on this. I'm not sure whether you've grabbed this episode yet, but we have done an episode on born before arrival. I think that's what the technical term is. But I've forgotten what the name of the ep is, but we'll put the link in the show notes. So maybe have a listen to that, because we then go on and talk about some practical tips to prepare just in case that baby arrives at home or in the car or, so that might be just a little bit of swatting you need to do there to, to
prepare.
To prepare. Great. Good luck. All right, Pat, let's move to this caller.
Hi, Dr. Pat and Brigid. Thank you so much for your podcast. I'm really appreciating learning from experts as my husband and I are trying to conceive. We've been trying for about 6 months. I followed your advice on going to see a fertility specialist if I have irregular cycles and found out that I have PCOS. I've been put on a course of letrozole, and I'm just wondering if that's something that you guys have had experience with prescribing to clients. What's the general time frame for when I might expect it to work in making me pregnant? And after how many months should I be following up with another appointment if I'm timing intercourse properly, according to the charts, but not having any luck? Thank you.
Thanks for getting in touch with us about letrozole, and this is certainly a question that we've dealt with before. It's an excellent treatment for an ovulation. It really helps some people ovulate, and if their fertility issue is thought that the only missing ingredient is the ovulation, and the sperms have been checked and they're fine, and the woman's there's no obvious signs of endometriosis, and we don't think there's tubal disease, and we think that the missing ingredient is the eggs, then it's quite reasonable to go on to letrozole, restore monthly ovulation, and carry on with that treatment for an agreed amount of time. Now, what's a reasonable amount of time? Well, it depends a little bit. How many babies do we want to have? How old are we when we start? And so how much of a hurry are we in? And then is there any evidence that anything else could be wrong? We'll look at that. And then is it working? So when we give the letrozole, are we sure it's working? Are we sure that it's making us ovulate? And then in discussion with our reproductive care team, that they will be able to guide us as to how long we should keep using that treatment. So you remember, let's say, for example, the only thing that the couple are missing is a regular ovulation, and letrozole fixes that. That just brings that couple to the starting line with everybody else. And it doesn't mean you'll get pregnant the first cycle or the second cycle. It just means that you are now you are now rolling the same dice as everybody else. And if we looked at another couple your age, we might not get worried if that couple weren't pregnant for at least 6 months of trying, perhaps 12. So we've got to factor in that letrozole replaces something that's missing, but it doesn't, or fixes something that's missing, but it doesn't necessarily magically get us pregnant, just like a natural cycle wouldn't work every single month. But it really, how long to try an individual treatment really depends on individualised factors like maternal age, how many babies do we want to have, and does this treatment appear to be working?
Can I just say, how do they know that the treatment is working?
Well, we can do a day 21 progesterone test at least to prove that it's made us ovulate. And then also, if you ovulate on day 14, you're very likely to have a new period or a positive pregnancy test at the end of that month, perhaps by day 29. So, we can see that it's working. If we conceive, fantastic. And if we don't conceive, well, we're better off than we were before we started the letrozole. We keep going for an agreed number of months before trying something else. And how many months? Very individualised.
Yeah, great. All right. Well, I hope that's given you lots of. It sounds like it's given you a few jobs to do.
Yeah.
Good. All right. Let's move on to this one, Patty.
Hi, Pat and Brigid. I just thought I'd give you an update. It's Michelle. I had previously asked the question why I was still lactating about 8 months after I had stopped breastfeeding my son. And it turns out that I had a microadenoma. So my GP ordered the prolactin test. It was very high. Did the MRI. I found out I had a 0.7 millimeter microadenoma, which my endocrinologist then said was directly related to why I was getting irregular periods. Because I didn't mention it before, but I was having trouble falling pregnant again for my second baby. So after 2 months of being on Dostonex, my periods became regular, and I'm now, where am I? I am almost in my third trimester of being pregnant. But so thank you so much for the information you gave for my question.
Fantastic.
That was a new medication I've never heard of, on Dostonex.
Dostonex.
Oh,
yeah.
Dostonex.
Yeah, Dostonex is cabergoline, which is a drug for switching off prolactin secretion in the brain. So we use it for people who've got small, tiny little tumours within the pituitary gland that are producing prolactin, breastfeeding hormone. And we also use it to switch off the breast milk in situations where people want to stop feeding immediately, or they don't want the milk to start. So sometimes, for example, in a tragic stillbirth situation, it seems like an additional slap in the face if the breast milk comes, and people sometimes say, can you stop the milk coming? And this drug will do that. You just take 2 pills and it stops the production straight away. Other times, if people just don't want to breastfeed, then just not having the baby on the breast, it'll stop eventually, in most cases.
But not in hers.
But not in hers. Fascinating. So eventually a pathological cause was found for that. The same drug turns off the prolactin in the brain, being produced in the brain, and in the presence of that breastfeeding hormone, it's hard to ovulate normally. And if you switch it off, ovulation comes back. Bingo, pregnant again.
Yeah, right.
Fantastic.
Okay, so what is a microadenoma?
Just a tiny little tumour within that gland that doesn't do anything terribly bad. They're benign. They don't spread to other parts of the brain or other parts of the body. They can be hormonally active, so they can be a rare cause of fertility problems. They make people who lactate who aren't, who don't want to be. And big tumours of the pituitary gland can cause things like problems with your eyesight, but little tiny ones typically are asymptomatic apart from their hormonal effect.
How great. Thank you so much for coming back to us and telling us why you were still lactating 8 months
Fantastic.
after.
Diagnosis, treatment, success.
Yeah, good on you.
Love it.
And congratulations. I think we've got time for one more, Patty.
Hi, Dr. Pat and Brigid. Thank you so much for your podcast. I'm finding all the information very helpful. I've been listening to it in the lead up to trying to get pregnant, and fortunately I'm pregnant and 16 weeks along. Bit of background for my question. I had a couple of DNCs, the most recent being a result of a miscarriage last year. After the DNC, it was discovered that I had Asherman syndrome, which is the adhesions and scarring in my uterus. The doctor at the time advised that due to that scarring that they would classify me as high risk and that I'd need to see an obstetrician as soon as I fell pregnant, which I have done, and all is progressing well. But I did forget to ask at the time, and now I'm just interested to know what might make it high risk, I guess, the scarring, but in particular, is there anything that I need to be aware of during this pregnancy, things to look out for or just be more wary about, just because of the scarring? Thank you so much.
It's always tricky when someone says your pregnancy is high risk.
Yeah, it is, isn't it? We probably shouldn't throw that term around quite as much as sometimes we do. This is another very generous person who's got in touch and shared this story. Asherman syndrome is where scarring can happen inside the uterus, often as the result of repeated curettage, where the front wall can get stuck to the back wall and the cavity of the uterus obliterated by scarring. It's treatable. We can go back in, break down those adhesions, and reset things so that a normal lining can grow back. And the Asherman syndrome in itself is a cause of often of infertility, but it can be treated. If someone's had Asherman's and it's been treated and then they get pregnant, there's always a possibility of the presence of that internal scarring, albeit treated, could cause problems with placental attachment. Okay, and that's what I'm guessing they were getting at when they said that the situation was high risk. And when if the placenta is abnormally attached, then it can be associated with a postpartum hemorrhage. And sometimes if somebody has had a history suggesting that they might have an abnormally attached placenta, such as someone who's had that before, or someone who's had a very large number of caesarean sections and then gets a placental attachment in a new pregnancy that's directly over the scar from all the sections, or perhaps someone with a history of Asherman's, then sometimes we can do tests during the pregnancy to have a look at how well or abnormally the placenta is attached, and MRI can be useful for that. But at the very end of the day, if we're worried about an abnormal placental attachment, we may actually not know whether it's truly abnormally attached or not until the baby's out and we're trying to get the placenta removed. So in this situation, we might just give advice that is more along the lines of having a baby in hospital, care team that's aware of the possibility of an abnormally attached placenta, and some low-risk interventions such as an intravenous line in the back of our hand in case we need to give drugs quickly in the setting of hemorrhage. Okay. Not panicking, but not doing nothing either. Yeah.
So high risk in the term that she'll be sort of more closely monitored. She might have more ultrasounds or... placental problems can be associated with growth problems in the baby. So, for example, if we're being particularly cautious, we might recommend, in this case, an additional ultrasound in the third trimester to make sure the growth is carrying along normal range. Yeah. An expert ultrasound to look at how what the placental attachment looks like. Consideration of an MRI if we're not sure. Birth in a hospital where we can deal with an abnormally attached placenta if it happens. And of course, lots of the time when we're worried about this stuff, absolutely nothing goes wrong. Yeah, that's right.
Yeah, which is why we don't want to overdo the interventions. About being prepared and fewer surprises. Yeah.
Good. Well, I hope that's given you peace of mind, and that it doesn't, the not diagnosis, but the classification of high risk isn't the thing that rules your pregnancy.
No, exactly right. Yeah, that's just a piece of information that should be taken into consideration, and there are still plenty of choices there as to how you'd like to handle that, and what we're dealing with at this stage is just information. Yeah.
Great. All right. That's it. I think we've done well.
Good.
Yep, good. We answered lots of questions. We've got a few more there, but keep them coming because there's such variety.
Yeah, and
it's incredible.
It's terrific, and people aren't getting in touch saying, "Thank you, I conceived on the first try and had a perfectly normal pregnancy. See you later."
Yeah.
We do hear about abnormalities in these Q&As. But the thing in obstetrics is these are everyday abnormalities. Some of it's rare stuff, but lots of it is just common
things. Yeah.
Super severe preeclampsia is quite rare, but the disease itself is not rare at all. These are conditions of interest to the general pregnant population because it's in one form or another it's not terribly rare.
And if you're a listener and you're listening along to these and you love the information that you get from Pat and I, you might like to come into our Grow My Baby program. So it's $197. It follows you throughout your entire pregnancy. However, you can join at any time in your pregnancy. We go through first trimester, second trimester, leading up to the labour, birth, and then 6 weeks postpartum. We've got obviously the expertise from Dr. Pat, but we've also got an anaesthetist, a physiotherapist, a dietitian, and some post-birth help from our sleep specialists. So there's just tons and tons of information that is like having a whole care team in your pocket. So, yeah, you can find that on our website, which is growmybaby.com.au. Otherwise, we'll put that link in the show notes. So, until next week.
Thanks for listening, everybody.
Thanks for listening. We'll see you then. Bye for now. Hey, even though Dr. Pat is, well, a doctor, and we get lots of other doctors and other experts on our podcast, I just need to remind you that this podcast is for informational purposes only. We share lots of medical insights and experience, but everything we talk about is general in nature and may not apply to your specific situation. Please always consult with your own healthcare provider for your individual medical advice when you grow your baby.